My case study was on a lateral lower leg projection. The first thing that I did was I checked the requisition. My patient was a 54-year-old male complaining of general lower leg pain. I went to set up the room by placing a sheet on the table. I detented the tube. The SID was at 40 inches. I used a 14 by 17 inch image receptor in the table bucky, placed portrait. The control panel was set up at 70 kVp and 4 mass. I then went out to the outpatient waiting room, got the patient's chart, and called the patient. I escorted him back to the exam room where I checked his name and birth date with his armband and the requisition, and then I asked him what was going on. He had been in previous motorcycle accidents and had numerous x-rays over the years, and he was having pain in his lower leg, and so it was getting worse, and his doctor wanted to make sure that there was nothing going on. So I explained the exam to him, and then I had him lie down on the table. I positioned him by rolling him mediolaterally onto his left side so that his lower leg was parallel to the image receptor and that he was in lateral position. Collimation-wise, I collimated transversely, but I left it open so that there would be overlap because I had to do 2 images, one for the knee joint and then one for the ankle joint. I centered the CR for the knee 1 inch distal to the patella, and then I marked the left side with my marker. I had him shielded. I told him to hold still, and then I exposed. So now we can look at the image. Okay. I don't know if you can see, but there are markings up here on there's skin markings on the upper leg, and that is from he was wearing pants. I didn't have him remove his pants, and I should have, because as we know, digital images will show everything. So those should have been removed to make sure that there was no mistakes made by thinking that there was something there when there really wasn't. So as far as rotation wise, we can clearly see that the femoral condyles are nowhere near close to superimposition. The patella has been foreshortened, and also, let's see, you can see the tibial tuberosity right here. You should not see that. Let's see, the fibular head is not supposed to be more than half superimposed, and as you can see, the entire fibular head is superimposed. The fibular midshaft is not demonstrated free of tibial superimposition. You can see it almost just completely covers the tibia here, or the fibula, excuse me. And it's the same on this image. So, positioning wise, I did not rotate the patient lateral enough. And I also did not bend the knee. The foot was not flexed. I also did not remove the grid, but I think as far as there is still uniform brightness, and you can still see all the cortical outlines and bony trabecula. So the main thing here was rotation. The patient was not rotated laterally enough. So according to the radiologist, there was no tibial or fibular fracture seen. The soft tissues appear normal, and there is no radio-opaque foreign body. So his impression was that there was no acute bony radiographic abnormality. So now we decide whether it should be repeated. I mean, clearly it's a suboptimal radiograph. It did not get repeated. I probably should have repeated it, but then you have to expose the patient to more dose, and you don't want to do that. So the radiologist didn't feel it necessary, so it was not repeated. So that is my case study. Thank you.